This is an interesting case that I happened to see today. Thought I'd share it with you. Here's the impression from the dentist. It's the maxillary impression. This is for a 6-unit bridge, as you can see, from cuspid to cuspid. And it's taken in a stock plastic tray with 2 phases of material. We can see some evidence of material beyond the margin, which is something that really excites me. And some of them, it's kind of a close call, but we did not have a difficult time trimming these dies. The technician said it was pretty straightforward, no issue. This is the one with the soft tissue on it that's going to be used to seat it. The first thing is the doctor prescribed a PFM bridge for this 6-unit bridge. And could you have done this in solid zirconia? Yes, you could have done it in solid zirconia. But there's nothing wrong with doing it in a PFM as well. I've said many times on this program that while I haven't done a single unit PFM since 2009, I continue to use PFMs for bridges. Now, I might not have done it exactly on this particular bridge because the bite forces are definitely weaker, much more so in fact than in the posterior. So the fact that solid zirconia bridges can fracture more, especially with multiple ponics, than say a PFM bridge in the posterior, doesn't necessarily drive me away from this. But you can see how when we talk about the rule of 27, we've talked about that before, about how the vertical connector and the horizontal connector, especially on a posterior bridge, needs to be 3 millimeters by 3 millimeters. It's difficult to measure as a dentist, even if you try to take calipers and measure this and measure it and say, oh look, it's it's 5 millimeters tall here. Well, it's really not though, because we're looking at the ceramic material too and not just the metal substructure. But typically on anterior bridges like this, because we can make this vertical connector as tall as we can on anterior teeth, this ends up making these bridges rule of 27 compliant, because if you'll recall, the actual rule of 27 is the height of the connector squared times the width. And the reason the height is squared is because that's the more important of the two measurements, because all the biting forces are coming this way against the vertical component of the connector. And so if you have a vertical connector that's tall, say 5 millimeters tall, you can get away with something thinner that's maybe 2 millimeters or 1.5 millimeters facial lingually, because of how tall that connector is. Oftentimes in the posterior, the opposite's true. We have a really short vertical connector, and you would have to make the width of the connector unusually wide to try to make it work. So this is probably a bridge that could have gone either way. Nothing wrong with doing a PFM bridge here, but probably could have been solid zirconia at the same time. So kind of the doctor's call on which way you want to go, whether it's going to be a PFM or whether it's going to be a solid zirconia bridge. The interesting thing on this case is that when you look at the opposing model, the patient is missing a lot of posterior teeth. In fact, I'll bring that in right now. It's a little difficult to see because the doctor is having a partial constructed at the same time. So this is what a CAD/CAM partial looks like if you haven't seen one before. And this gets printed up on a 3D printing machine. We've looked on the show before, and I've shown you how we can print up a PFM coping, we can print up an e.max crown at a resin and then invest it and burn it out. And so this is a CAD/CAM partial, and the fit on these is really unbelievable, and that's why we've gone towards these rather than hand waxing them. So this has been designed in a CAD/CAM system on the computer, and all the casps have been put in after the model's been scanned and the undercuts have been found. So rather than using a surveyor like we did in the old days, we've got the CAD/CAM accuracy of knowing where the height of contour, knowing the undercut measurements, kind of like we do with looking at reduction on crown and bridge cases. CAD/CAM allows us to really see everything and measure it and quantify it, know exactly where it is. So on some of these clasps, you can see, just to keep them from breaking, that we have a little support structure that goes over the tooth. So this is going to be cast in metal and then cut off afterwards. You can see this cross arch bar here on the lingual to provide support for that as well. So this gets printed on that 3D printer. It's probably not strong enough to try it in intraorally. As you look at this, you might think, wow, I could have the lab send me this. I could try it into the patient's mouth, see if it fits, send it back, and then have them sprue it. Right now, the resins that we're using, the available resins, aren't quite strong enough. If you try this in, and especially when you pop it out, it's very easy to break the clasps on these. So we're looking for a stronger resin. And we do kind of envision a day where we can send this to you, you try it in, and without us having to go all the way to finish, you know whether or not this is going to fit. And then we process this exact same frame for you and send it back, so you're very confident at the delivery appointment about how this partial is going to pop into the patient's mouth. We've sprued it in 3 spots. We have our little reservoir here. So this will be lifted off of here. We don't need a refractory model anymore because it's not waxed on. This will be very carefully lifted off of here by the technician who finished this, and then it will be invested and then burned out and then cast in metal in this exact same shape. But they're really the CAD/CAM part where we scan the model, so it's even more important to get very clean impressions like you've hopefully been doing in the past for these. We scan the model and design it in a CAD/CAM environment so we can see exactly where the undercuts are. We can see exactly how long these clasps have to be. And so I'm just wanted to show you what a CAD/CAM partial looks like after it's printed and before it's cast. Most dentists haven't had an opportunity to see these before, but we're lacking a lot of posterior support across from these teeth. And the last thing I wanted to show you was the doctor's creative use of bite registration material, and it's a blue moose bite that was taken. And you can see that what the doctor did was leave one of the temporaries in place to act as an occlusal stop. So obviously, when you have all the teeth prepared, as you have here, and you're going to have the patient bite down and there's no posterior teeth that are going to be in contact with these, the patient's going to overclose. And so what the doctor did was leave one of the temporaries in, sitting on the lateral incisor as a stop. You could have made an argument for doing it on both of the cuspids, maybe, so you had a stop on both sides. But as long as it was a solid stop where the patient closed against that lateral and didn't move, didn't slide, then you can take the bite registration and maintain the vertical like that. And bonus points to the doctor. This might be the first time I've ever seen this. And this is, we'll zoom out just a little bit to give it some perspective. This is a coat hanger that has been fashioned into a bite registration. And so essentially it looks like what the doctor did, I wasn't there, but it looks like he sent the assistant to the closet, took one of his lab coats off it, and then cut the coat hanger and then fashioned a handle out of it, and then put red wax around here to help hold this gauze on. I'm not even sure I have this laying around the office. I don't know where I would get this. I would have tried maybe toilet paper. Maybe a patient bib actually would have worked well. And then squirt. I guess you got to make sure this will fit in the patient's mouth. You don't want the ends of the coat hanger lacerating the cheek. And so you bend it in to make sure it'll fit in the patient's mouth. Put the temporary in place, maybe with a little temporary cement, or just cure it on with a little Flowable, or maybe there's enough retention to keep it on there. And then squirt your bite registration onto both sides and have the patient close into it, have them open again, and then you're able to have it all in one piece. Sometimes these stiff bite registration materials like Blue Moose have a tendency to break, but you can even do it in thirds. There might be, you could see sometimes we'll do it in thirds. I can't tell if the doctor did this in thirds or if it broke subsequently. But big props to the doctor. This is the first use I've seen of an intraoral use of a coat hanger. And so I just wanted to give props. The doctor did some very nice preps, took a nice impression, and we're going to be able to send back a nice CAD/CAM partial in addition to the nice PFM bridge that we have here. But bonus points for thinking out of the box and using a coat hanger intraorally to get this bite registration. The closest I've come to this is sometimes I'll use old burrs and I'll nail them into the wall and then hang like a diploma on it or something like that. But I've never gone reverse and taken like something like an ordinary coat hanger and used it in the mouth. That's as MacGyver as it gets in dentistry. So hats off to this doctor for a unique way of getting us an accurate bite registration.